So it's not every day we get the privilege to talking with one of the top researchers in the world, but tonight Dr. Mike Hansen and I would like to introduce our distinguished guest, Dr. Bruce Patterson. Dr. Patterson graduated with a degree in molecular biology from the University of Michigan, Doctor of Medicine focused in virology from Northwestern University, Associate Professor, Director of... Alrighty, so all right, Mike, can you hear me?
Yeah.
Dr. Patterson?
I can hear you.
All right, great. All right, so we'll just get started. So it's not every day we get the privilege to talking with one of the top researchers in the world, but tonight Dr. Mike Hansen and I would like to introduce our distinguished guest, Dr. Bruce Patterson. Dr. Patterson graduated with a degree in molecular biology from the University of Michigan, Doctor of Medicine focused in virology from Northwestern University, Associate Professor, Director of Diagnostic Virology at Stanford University School of Medicine, and is the CEO of molecular diagnostics company IncellDX. Hopefully the LinkedIn profile was up to date, Dr. Patterson. I just want to thank you for joining us tonight. I know we have an excited audience, and just want to quickly go over the format for the session before we turn everything over to Dr. Patterson. Dr. Hansen, Dr. Patterson and I will be having a roundtable discussion. Dr. Patterson's got a lot of great things he would like to share with us. We got a couple of questions for him, and then we'll open everything up for a question and answer. So everyone, please hold off on any questions, and we're going to turn the floor to Dr. Patterson. So thank you very much.
Thanks, Mike, and thanks, Ram. It's really a pleasure to be on here. I really enjoy your show and the information that you've been able to communicate to the public. I think is absolutely critical. This is a very complicated disease, as you know, and what we're doing is very sophisticated, and I think it's really helped explain the approach that we're taking using through your show, and I really appreciate that.
So thank you very much, and we've both been a big fan of your some of the writing, some of the things you've been publishing, especially the Montefiore study and the manuscript, the abstract. So we're really excited to hear kind of like the behind the scenes and some of the additional information you might want to share with us.
Yeah, it's great to have the time to actually talk a little bit about where we've come and how we've gotten here, and it's a very interesting story. And as you may or may not know, I started HIV research in 1989, 1990 thereabouts, and
sorry, Dr. Patterson, would you mind just moving a little bit to your left so you can get on camera? There you go.
Yeah, so it all started back in the early 90s. Obviously, we were going through something very similar today, so it doesn't seem so odd to those of us who lived through and were participating in the research that was going on in the HIV/AIDS epidemic. And we were one of the first ones back in the mid 1990s to identify CCR5 as a co-receptor and a receptor for HIV, but then also start studying, where was CCR5 expressed in the body? What was its role? How was it regulated? And as it relates to COVID, we found some very interesting things. Like number one, that CCR5 is regulated by cytokines. So when you start talking about cytokine storm that occurs in influenza and other viral infections, that's going to play a significant role in the expression of chemokine receptors and chemokines. And these are really the magnets for immune cells, if you want to overly simplify it. RANTES, which we discovered now two and a half months ago, is being significantly elevated in COVID infection, is really the magnet that's pulling all these immune cells into the lung, where they produce more cytokines, more chemokines, and it's a vicious cycle. And frankly, that's the tipping point. That's the switch point where you go from a viral disease to more of an immunologic disease. And it happens early. As we showed in the paper, RANTES is 5 to 10 times normal in the mild to moderate patients even, and over 100 times normal in severe and critical patients. So when you have that level of essentially a chemoattractant or a magnet pulling immune cells into different tissues, you're going to have pathology. And then later on, you know, we referred to literature that shows that RANTES is involved in renal failure. RANTES is involved in elevated liver transaminases and liver transaminasemia. So, and also RANTES is produced by activated platelets, which can form thromboemboli and account for some of the coagulopathies. So it's been an amazing ride. And then just recently, we see these kids popping up with Kawasaki's or Kawasaki's-like diseases in New York. And of course, Kawasaki's is caused by high levels of RANTES, which causes inflammation in the arteries. So we're very excited. Papers are now coming out, also publishing on high levels of RANTES and COVID. And so we're getting the kind of scientific validation of our early findings. And of course, we're well on our way towards treating these high levels of RANTES or blocking these high levels of RANTES and their role using Leronlimab as we published in the paper and we've been talking about. So it's a very exciting time. And like I said, I think we have this switch that causes the disease and a treatment to take care of that disease. And you know, the other things that we found that aren't in the paper, I mean, Leronlimab relieves some of the immune exhaustion. And one thing you see in T lymphocytes in COVID is that the CD8s and the CD4 T cells have exhaustion markers, PD1, LAG3, CTLA4, which seem to improve, you know, following Leronlimab therapy. And then the other big role of Leronlimab is on macrophages. We showed both a significant decrease in interleukin-6, even within 3 days of Leronlimab therapy. And we showed it both at the protein level in plasma and then doing single-cell sequencing. We showed decreases in interleukin-6 RNA. So, you know, taken all together, we've shown, you know, a restoration of the immune response. We've shown a decrease in cytokine storm, a quieting of the cytokine storm with decreases in interleukin-6, TNF-alpha. And last but not least is the fact that following Leronlimab therapy, we actually saw a decrease in plasma viral load. Now, plasma viral load has significance because, frankly, it hadn't been reported before and certainly not quantified before like we did with a super sensitive digital droplet PCR technique. And we're still trying to ascertain whether or not the RNA that we found is decreased by Leronlimab in plasma is RNA remnants from the virus or actually live virus. We've heard reports that there was a transfusion-related transmission of COVID in Canada, and we're collaborating with UCSF to look at whether we can grow the virus out of plasma, and I believe they even found a unit of blood that had COVID RNA. So, you know, the take home from that aspect of the paper is we need to be concerned about our blood supply in addition to, you know, looking at the role of Leronlimab in treating these patients.
Dr. Patterson, I actually wanted to ask you a question because a couple of weeks ago, I think you were on the conference call, and there were two things that really stuck out for me when I started to kind of dive into your work and start doing my own research and trying to put everything together. You were saying one was you were very emphatic by saying this is a RANTES disease, and I remember listening to the conference call and going, oh my God, I think we sort of talked about it offline. I remember it from med school almost 17 years ago, just kind of one random chemokine you kind of have to know for a immunology test. And my question for you regarding RANTES is, why do you call it a RANTES disease? Because there are some physicians and some things I've read and people I've talked to that say, well, it's not really a RANTES disease. There are other cytokines, and you were very emphatic and very resolute in saying COVID-19 or some of the complications are due to RANTES. And my second question is regarding the blood supply. If you can just maybe talk a little bit more about that issue, because after you mentioned that, I've talked to a couple of other physicians and virologists, and they've sort of shared some of those concerns with me, but obviously hasn't been talked much in the media and in the public. I think maybe there's a fear factor that are we going to scare the general public, because we're dealing with a respiratory infection, and now we're having to deal with potentially our blood banks being contaminated. And I thought from that conference call, those are probably the two big things I took from what you said. So if you could sort of kind of go into a little bit more detail about that, that would be great.
Yeah, absolutely. And, when I said this is a RANTES disease, I like to think of it, like a football team. RANTES seems to be the quarterback. That's not to say that there's not 10 other players on a football field, and it's not to say that there aren't other factors going on in COVID-19. I mean, it's a very heterogeneous disease. As we're going through our clinical trials with mild to moderate patients and severe patients, the data is extremely exciting. I mean, I can look at it and see patterns, even though I don't know, from a blinded standpoint, who's getting drug and who's getting placebo. I'm seeing some effects that are pretty dramatic, even in the mild to moderate patients. And so back to the analogy, RANTES does seem to be the quarterback. It's all about, sequestration of immune cells, exhaustion of immune cells, bringing in immune cells that make more chemokines and more cytokines. I mean, that's why we were thrilled when Leronlimab decreased interleukin-6. When there's other interleukin-6 therapies out there, we can say, well, we got that one, right? We got that checkbox. We got the checkbox of, restoring immune cell numbers. We got the checkbox of relieving some of the exhaustion markers. We got the checkbox of bringing the virus down. So, again, some of these other approaches are piecemeal. I mean, you can sit there and say, well, I'm going to use a IL-6 inhibitor or, receptor antagonist, or I can use a GM-CSF antagonist. I'm going to use a TNF alpha antagonist and come up with a cocktail of about 17 different drugs. Or, you can accept the fact that this is a RANTES disease, insofar as RANTES is the quarterback of all these findings that they're popping up. And again, I'm sure there's other things at play. There's no doubt about it. But the success with which these patients are recovering, 26 out of 28 patients in the UCLA cohort, again, under emergency use, all getting better. And out of 28, 26 out of 28, the other cohorts across the United States in the emergency use. And then the two most dramatic are the two patients who have come off ECMO, or essentially life support. And, to me, patients coming off life support, anecdotes don't come off life support, right? If we were to say, well, Leronlimab decreases the hospital stay to 9 days from the 11 days reported by remdesivir, I would expect people to say, well, that's anecdotal. You're going to need the statisticians to weigh in on that in placebo-controlled trials. And I get it. We're doing those. And I'm very excited about those results. And I'm very excited about how those trials will turn out. But the fact is, we've had two people on ECMO get better, are in either rehab or discharged from the hospital. And to me, being a pathologist for almost 30 years now, you have to have some common sense and say, these people, they were failing all the other drugs. They were 30 days plus on ECMO in the ICU. They had no other options. They're given Leronlimab, and the patient in San Jose was off ECMO in 3 days and actually just celebrated Mother's Day with their daughter, with hugs and in person and at a rehab hospital. I mean, those are the gripping tales that we're hearing. And like I said, yeah, we're going to do all the right things and do the trials with placebo controls. But you know what? Common sense just tells you these people were headed for, for a one-way street, and we changed the course of their disease and take it for what it is. But you know what? That's the thing that keeps me working all day and all night towards getting a solution to this disease.
And in terms of the blood bank or the blood supply, is that something you would recommend or suggest to hospitals or clinics to screen that blood? I mean, what is something like we should be thinking about?
Listen, I think it was a first report that we might have a problem, and I'm not. You have to be diligent about it. It was a huge problem in HIV. It was all about the blood supply, and we didn't have the techniques that we have today to really look at that. And NAT testing, as you said, or nucleic acid testing, is done by blood banks to look for HIV, hepatitis C, hepatitis B, and West Nile. West Nile was added to NAT testing when that was found in the blood, and I think we have to address this in the same way. I mean, we're actively scrambling to get the plasma and the whole blood to UCSF to see if this virus in the blood is infectious. I mean, that's absolutely critical because it could be RNA. Seeing the RNA change the way it does, I think that would be a great scenario. But frankly, I'm worried. And we should be, but we don't have all the answers as of yet. But we certainly should be very, very diligent and rigorous about finding an answer to that.
And what has been the reception you've gotten from the medical community after you came up with a statement like that? Because me personally, I took what you said and shared it with many of my colleagues and other physicians, and they said, "Oh, it's scare tactics. It's not possible." And I said, "Well, Dr. Patterson mentioned this, a respected pathologist and physician and a researcher. I mean, we have to consider it." And that's the sort of reception I had gotten. I mean, what were some of the things, at least from your end, the reception from the medical community? Was it, "Oh, Priest Patterson is scaring everyone"? I mean, what was the sort of reception you got?
No, I mean, the first few calls were the blood banks, and I think they had the same response that I do. I'm not trying to scare anybody. I'm just trying to protect people. And we're still a ways away from determining if the virus is infectious in the blood, and that RNA actually represents infectious virions, but got to do the testing. I mean, the fact is, it's there. And like I said, I'm not trying to scare anybody. I'm just saying, like any other viral infection, we have to take a look at it. And it was the same response back, in the HIV years. Nobody would believe that, we had an issue with the blood supply. And indeed, we did. And it's not a scare tactic. It's just based on 30 years of experience and being a viral pathologist and going through a pathology training as I did, and blood bank and everything. It's just it's my job. It's my job to worry. It's not my job to incite fear. It's my job to worry, and I'm taking the appropriate steps to figure out if that virus is infectious, and that is the next step.
Dr. Patterson, I want to ask you, so there's recently a video I made that was talking about a study that was done in the Annals of Internal Medicine that looked at the autopsy of 12 patients in Germany, and they concluded that all 12 of those patients died due to lung pathology. 4 were the direct result of pulmonary emboli, and the rest of the 8 were due to ARDS, severe pneumonia from COVID. In some of these autopsies, not just the ones in this study, they're showing that there's CD4, CD8 lymphocytes being, migrating as you describe it as a magnet, migrating to sites of pathology like in the lungs. But there's also myocarditis with lymphocyte infiltration in the heart as well. I don't think I've seen any reports of that lymphocyte migration in brain or kidneys. At least I haven't come across that yet. They did see the virus in the kidneys with electron microscopy. What is your take on lymphocytic infiltration in different organs playing a role in the disease?
Well, listen, I mean, the way I look at it, the body's on fire, and a third of the hospitalized patients have renal disease. Okay, and it's very prominent in the literature, the role of RANTES in, some of the interstitial nephritis, some of the other renal diseases, by the mere fact that it's upregulated. RANTES is expressed by lymphocytes. That brings in more immune cells, and again, you get into these little localized vicious cycles, which need to be broken. And same with the liver. We haven't looked so much at the brain, but fact is, liver, kidneys, and the fact that activated platelets make a ton of RANTES and bring in immune cells and cause thrombi, microthrombi. It's really remarkable. And this day, all of the patients, probably almost 100, not including the trials, being treated with Leronlimab, we haven't seen one with a coagulopathy, which is again anecdotal, but very interesting that we haven't seen it when it's so prevalent, in other studies.
Dr. Patterson, going back to the whole thing with RANTES, I feel like it probably in the last week or two, there's been a lot more research and studies coming out about RANTES. I think you might have started, got a lot of people interested in at least RANTES and COVID-19. Obviously, it's been studied in many other. But that was one of the sort of comments I've been getting from a lot of people is I think there was a study in China where, I don't know if you've come across it in the last couple of days. I think they said that RANTES was elevated mostly in the early part of the disease. I've got the manuscript here, and they said the disease severity correlated more with increase in interleukin 10 and interleukin 1 receptor antagonist, meaning the anti-inflammatory cytokines are kind of playing a role in the disease severity, and the early part is more RANTES driven. I sort of try to dive in through your Montefiore manuscript and some of the data you have, which shows something much different. It was really RANTES driven. How do you, if someone were to say, well, how do you account for this discrepancy or what these researchers said as RANTES early rather than didn't have an effect sort of in the later part of the disease course? What would be your thoughts on that?
We're seeing the same things. We showed RANTES in mild to moderate disease, and I think that fits with our hypothesis. And we have a panel of almost 50 cytokines, chemokines that we're looking at, and we didn't see any correlation with interleukin 10. Certainly, interleukin 10 is high early. So, the other thing that we found that we didn't publish was, it seems to be a predominant type 2 cytokine, predominance early, at day 0. There's very little interleukin 2, very little interferon gamma, which you would expect in a viral disease. There is high interleukin 10, relatively high interleukin 4. But the fact is there is RANTES 5 times to 10 times normal in mild to moderate disease. But, when you see RANTES levels of 50,000, 100,000 picograms per mil in these severe and critical patients that we've looked at, there's just no arguing that that it's involved in the pathology in this group. And it's not unusual that there's different presentations, in different studies at different time points, because no one, they keep redoing the classifications of what is mild, what is moderate, what is now different severe versus critical. So now there's almost 4 different stages of COVID. And the fact is, RANTES is elevated throughout. We see this enormous gradient of RANTES depending on severe severity, and we saw it consistently. It was consistently, 80 to 130-fold elevated over normal in these criticals. Whereas you'll see interleukin-6, some patients have 1,000 picograms per mil of interleukin-6. Some had 50, right, in the criticals. So, it was interleukin-6 was elevated, but by no means as consistently elevated as we saw with RANTES. But, again, I think the good news is it's being discussed. The good news, people are finding it at different stages of disease. And frankly, like I said, I think it's starting this mass migration of immune cells and this vicious cycle of, immune cell migrating into different tissues, making more cytokines and chemokines, more immune cells, more cytokines, chemokines, and then you get these immune sequestrations, you get immune exhaustion because of the continuous antigen stimulation. And that's part of the pathology. But again, we're learning more and more every day, and we're because of the success we've seen with something that blocks RANTES, I think the mechanism of action is actually fitting the therapy that we're looking at.
I want to ask a question about. I know we're talking about RANTES being secreted by different parts of the immune system and platelets as well. Do you know of a connection between that and the downregulation of the ACE2 receptor with less angiotensin 2 in the lungs and more angiotensin 1,7, 1,9, less stimulation of the MAS R receptor in that pathway?
I mean, we haven't really dived into some of the virologic pathways. We're more focused on obviously the immunologic pathways and immune pathology and how that's influenced by blocking CCR5. But, frankly, I mean, we've seen reports in the first SARS epidemic that even the epithelial cells infected by SARS were making RANTES. So, again, we haven't, and this is similar to HIV, where, there was parallel paths between the virologists and the immunologists. And there was very little crossover early, and then I think at the end of the day, we figured out that you can't have one without the other. And I think eventually we're going to find that here, but there seems to be a more clear demarcation between a viral phase of COVID and an immunological phase of COVID. So we've focused more on the latter, which, if you look at a disease progression figure, is from moderate maybe to critical, and we haven't looked so much at the early stages, the asymptomatic, what's going on in the asymptomatics, what's going on in the very earliest stages of viral replication that leads to where we come into play on the immunology side. So again, I think we're trying to put all that information together and see how it all fits. But there's COVID is very interesting, and think by the fact that there does seem to be a very, very clear viral phase and immunologic phase of pathology.
Now, I'm sure you're very aware vitamin D is all over the news, and vitamin D it plays a part in the immune system. There's the vitamin D receptor that's essentially expressed in all of our cells except for red blood cells, and then that alters gene expression and increases defenses and califedins and however you pronounce that. And they play a lot of different roles in the immune system by the actions of the vitamin D. And I just want to know, do you know of any link between vitamin D or vitamin D deficiency in relation to RANTES production and cytokine storm?
So we're now looking at the single cell level with single cell sequencing, single cell RNA, looking at the transcriptome and how things vary with different therapies, different perturbations. There's a lot still to be learned. We're obviously focused on some of the things that we're focused on. Again, we're trying to look more towards how are we correcting immune exhaustion. One of the other findings we're very excited about that we're pursuing is there's increased granzyme A and CD8s due to leronlimab. So what's affecting the transcription of granzyme A following therapy? Because granzyme A, as you know, are sort of the bullets of CD cells for both viral infections and tumor cells. And I think what's really fascinating about what we're doing with leronlimab is we're learning so much about what it actually does to the immune system that it explains some of the success that we've had in small cohorts of cancer patients. Maybe there's a function other than just blocking the HIV binding site of leronlimab in HIV disease. Nader Pourhassan, the CEO of Cytokine, mentioned that these patients feel better. They just feel better almost immediately on leronlimab, and I find that very, very interesting. And maybe there are other effects on the immune system in HIV. So does it increase granzyme A in CD8 T cells in HIV? Do you also alter your ability to eliminate HIV-infected cells? So not only blocking the receptor, but enhancing your immune system by inhibiting Tregs, which inhibit immunity, increasing granzyme A. I mean, we're going deep with some of these mechanisms that we've identified in the paper, and extrapolating how they may also be playing a role in cancer and HIV. So, there's not enough time in the day to look at, everything that's going on and every different approach. But, I think we have a very fascinating story, and we're starting to get answers why leronlimab is working in cancer and why there may be even additional benefits in HIV that go beyond receptor blocking.
Dr. Patterson, just to shift gears a little bit, in terms of clinical implications, I know initially in our talk you mentioned about RANTES and Kawasaki disease or Kawasaki-like disease. I know recently Cytokine and even with Dr. Lalazari talking about a pediatric dose, and because there's some literature suggesting, as you stated, that Kawasaki is a RANTES disease. Can you talk a little bit about the pediatric dosing and what you guys are looking at over there?
Well, Cytokine and IncellDX made an announcement on Friday that we would do the RANTES testing for free, for that patient population, and that offer stands. I mean, not only will we do RANTES, but MIP1 beta has been shown in Kawasaki's, MCP1, another macrophage chemotactic protein, has been shown to be elevated in Kawasaki's. The more we can learn about these kids and their clinical picture and their laboratory findings, the better. And I think we'll be able to address, what's going on in these kids, and you need that information before you treat them. And the other thing is we've developed receptor occupancy for leronlimab, where we take the drug itself, leronlimab itself, and we put a fluorescent tag on it. So we can use that. We signed a deal with Cytokine, IncellDX did, to use labeled leronlimab as a diagnostic reagent. And so we can see when leronlimab is bound by the decreasing fluorescence in the immune cells that it's bound to, which is, very elegant. And, what we propose for the kids is you can start off with very low dose leronlimab and know, to what degree do we have receptor occupancy and have the drug occupying, close to 100% of receptors. Maybe that's a much lower dose than we're using in adults. And so we would be able to titer leronlimab in these kids, starting at an extremely low dose and looking at a dose response in these kids until we come to a dose that starts to see relief of the symptoms. So we're actively working with all the various agencies and bodies to find some approach to identify how to help these children.
Dr. Patterson, 2 questions for you. 1, what are the side effects of leronlimab? And 2, when do you think, let's just say it works and it melts away the cytokine storm. At what point would it be worthwhile giving to someone? Would it be moderate disease with pneumonia, but not in the hospital? Would it be in the hospital, but not in the ICU, not intubated? Or would it be only for on the cusp of intubation, or they are intubated? At what point would you give the leronlimab if it does prove to melt away the cytokine storm?
Both great questions. I'll take the last one first. Because we can measure RANTES is a great biomarker. And so what we would do is in these patients, obviously if they access the healthcare, because their symptoms are such, you measure RANTES. If it's elevated, I think that's the time that you can cut off, the immune magnet and maybe short circuit the development of the cytokine storm, where all of a sudden, it's mass chaos within the immune system. So I do think there's an opportunity to hit it early, probably at first presentation to the healthcare system where RANTES could be measured. If you're asymptomatic or you just feel you have some minor symptoms, chances are you may not be going to to any healthcare facility at that time, and maybe it will run its course. And maybe there's other drugs that, like Tamiflu, where you have to, as soon as you get that first sniffle, you basically have to take this stuff, or it doesn't work. But I think RANTES is the perfect biomarker. Need to institute therapy, and again, because we can measure dosing and we can serially measure RANTES levels. As soon as RANTES goes down, which at least in severe patients takes at least 14 days, 21 days in some patients, you can say, well, maybe they need 1 dose, not 2, or maybe some of the ICU patients need 3 doses, not 2. But again, unlike the other drug companies, we developed a suite of diagnostics to be able to tell us exactly when do we institute therapy, how long do we have to continue therapy. We have markers to show that the drug is completely bound in patients who have significant inflammation. And as I said, our 1997 paper showed that inflammation cytokines upregulate CCR5. The type 2 cytokines downregulate CCR5. So, it's a moving target, and having the diagnostic capabilities to continuously monitor that moving target is a huge advantage in being able to institute therapy at the appropriate time and use our resources wisely. So, and Mike, tell me the first question, because I forgot.
That was great. You took the big one first. I respect that. So the second question was, are there any side effects of leronlimab?
So, the BLA for HIV combo therapy was just submitted It's a rolling review. There'll be a continuous dialogue between the FDA and Cytokine, and 800 patients were treated with leronlimab with no SAEs or serious adverse effects. That's amazing, and I think that's what has allowed us to move quickly into phase 2 and phase 2b3 clinical trials is the safety profile of leronlimab that's already been deposited with the FDA, and I think that's probably the best part about it. And then obviously the recent data that a third of the hospitalized patients with COVID have renal disease eliminates many of the drugs that are being considered out there for therapies because of their effects on kidneys. So
liver impairment too with some of the drugs.
Absolutely. So again, having that safety profile really is it's so significant for leronlimab as a therapy for any of the number of indications that we've discussed, and whatever comes up in the future. For instance, influenza, which also is a cytokine storm. I think that's something that hits every single year, and maybe in addition to maybe Tamiflu early, maybe there's a time when leronlimab comes in the moderate to severe influenza infections and curtails some of the morbidity and mortality in influenza that we see every year, which isn't trivial. So,
Dr. Patterson,
could there be a pill form?
No, but it's a once a week insulin-like injection. I think it couldn't be easier to deliver. I think there are some discussion about potentially altering the monoclonal, so you might even be a once a month injection. So I think that's the way forward. And like I said, if it's just a sub-Q insulin-like injection, I don't think you're going to get much pushback.
Dr. Patterson, in terms of clinical applications, if I had colleagues of mine in the ICU or ER, and if we wanted to draw serum labs to develop some sort of risk stratification of a patient who is more likely to have those cytokine storms and so decompensate, what, in your opinion, would be some of these? I know you mentioned RANTES as one of these biomarkers, but in order to get a full comprehensive picture, in your opinion, what would you say would be a recommendation or recommendations to my colleagues?
Yeah, Ron, that's a great question, and we are going to start working with some of the great bioinformatics people out here in Silicon Valley to look at these signatures of disease, and eventually, when the trials are done and the blinding is broken, we'll be able to say, let's take a look at the markers that are predictive of mild to moderate disease progressing to severe disease, or severe disease progressing to critical disease. And I think we'll have a much better handle on that. I think we have those capabilities, obviously, with bioinformatics and linear modeling and some of those things that, IncellDX has done for other of our, cancer diagnostics. So, we look forward to that day to be able to identify, signatures that predict, how a patient may respond or what's going on. I mean, for right now, I can look at a report, and the first three things I'm looking at are RANTES, interleukin-6, and TNF alpha. And frankly, if I see, and leronlimab's effects literally start at 3 days. I mean, interleukin-6 is already on the way down. By 14 days, it's close to normal. RANTES, depending on the severity of the patient, may stay up 14 days, maybe 21 days in the sickest, in which case maybe a third shot is necessary, but we start to see that come down. In mild to moderates, it comes down relatively quickly, maybe within 7 days. So I think once all this data becomes unblinded, and again, the trials cover the full spectrum of disease from mild to moderate to severe, and we've already looked at the severe to criticals. We will be in much better shape in terms of predicting, who fits where, how should they be treated, what's the strategy, and how do we think they're going to respond.
Do you have any updates on some of the clinical trials, the phase 2 and the phase 3 clinical trials with Leronlimab? Anything?
Yeah, I mean, it's very exciting. I think Dr. Pourhassen has come out and said, the end of May is, we'll have enrolled all the mild to moderates, and I think we're absolutely on target, for that deadline. Then we'll analyze the data, compile the data, and probably within 2 weeks be able to submit it to the FDA for, hopefully a quick turnaround. And, the severes are coming in now aggressively. I think, it took longer to get that trial initiated, but now they're coming in fairly steadily. So, we're working on 3 shifts at IncellDX looking at these patients, and, it's just steady flow, 24/7 of patient samples coming in.
And, just to touch upon a point, Mike, and you in your earlier discussion, I just wanted to sort of shift gears a little bit to remdesivir, because that's obviously been in the news a lot. And I thought something very interesting from the Montefiore study and the conference call that you had was how Leronlimab brought serum, the viral load, the plasma viral loads, decreased that. And obviously that's something we're not really seeing so much with remdesivir. And the second point I want to make was some of the patients that I've seen, some of my friends that have had severe COVID-19 infections, they have developed, from the cytokine storms, liver damage and renal damage. And the exclusion criteria, and this is on the clinical trial page for remdesivir and tocilizumab, is, I'll just read it out loud. ALT is 5 times the upper limit, Child-Pugh score greater than C, a grade C, which is severe liver disease, and patients with severe renal impairment, GFR under 30. So that's going to take your really sick COVID-19 patients that are having cytokine storms are now excluded from remdesivir. And I think tocilizumab is almost the same thing with the elevated liver enzyme. So it's almost like, yeah, we have this medication you guys can get, but, sorry, you're excluded from it. Whereas we're sitting with Leronlimab, which has there's no exclusion criteria. That's my understanding.
And that's as we saw early on, frankly. It was incredible how the shape that these patients were in, and what we've been able to do, the number of lives that we've been able to save is really astounding. And people, the reflex action is, oh, Dr. Patterson, that's anecdotal, but anecdotal or not, these patients walked out of the hospital. So whatever it is, I feel good about it. So, but you're right. So many exclusion criteria, and that's why it's hard to compare apples with apples and oranges with oranges, or apples with oranges, because each study is different, and what one person calls severe may be critical, at least early on, before they made better distinctions between the different groups. So it's hard to look cross studies, but you're absolutely right. And then just the data that a third of patients have renal issues that are hospitalized. I mean, again, we have no exclusion criteria for that, and others do. So at the end of the day, I think we're going to be able to help a broad group of patients, other than the ones who are asymptomatic and maybe the very earliest stages of virologic positivity. Everybody else is, like I said, there's a biomarker. As soon as they start increasing their RANTES 3 to 5 times normal, I think they're a candidate for leronlimab.
And that's
just to add on to that point, I want to say that, especially for our viewers that are watching, it's very hard to study drugs in general. And there's obviously lots of difficulties in interpreting studies. Most people don't know how to interpret a study, and so most people are just basing what they know on what other people are saying, what experts are saying. So the average person's not going to be able to interpret a study. Even people who have expertise in the medical field, whether it's scientists or physicians, even those experts have difficult time interpreting studies because studies are very complicated and there's lots of confounding factors that go into that and complicate matters. So there is no perfect study, but the best thing that we have are randomized controlled trials, and that's the best that we can get in determining if a drug works or not. And so a lot of the public is eager to get results, and understandably so, but we can't say anything with finality until we have solid randomized controlled trials one way or another. So it's understandable the frustration not being able to treat, but again, we don't know until we actually get solid studies in front of us. And if we're having a hard time interpreting these things, and scientists are having a hard time interpreting these things, the public is relying on us to deliver that information, and other scientists, and public officials. So it's very difficult.
Yeah, right. And again, that's why we're going through all the proper channels to to reach those endpoints. And that's why I was very surprised when the Remdesivir results came out. And of course, it was statistically significant that it reduced hospital stays from 15 to 11 days. But then the death rate didn't decrease. And then when you hear someone like Anthony Fauci, who's very black and white, and I respect him for that. But for him to say it trended towards, trend is a bad word in statistics. Trend means it wasn't statistically significant, but it was close, right? And so, you know what? In statistics, and when you're looking at these trials, either it's statistically significant or it's not. Trends, it's hard to get a paper published if you're saying, well, this parameter trended towards significance. Well, by the same token, how can you tell the public that, well, we trended towards a lower death rate when it wasn't statistically significant? It either is or it isn't. And if we're going to play by those rules, which we all agree to, that's fine. But don't use words that that deviate from that. But you're absolutely right, Mike. It's very complex, and it's difficult for for the general public to understand, when it's difficult for physicians and scientists to interpret. And again, there's so many variables that go into it, and exclusion, inclusion criteria, endpoints, and I mean, there really is a lot to it. And that's why I think it's so great that what you two have done in being able to communicate some of these very complex issues and try and really bring it to a common sense understanding of what what everybody else is saying.
And
with that said, I would give Dr. Fauci a mulligan, because he has an incredibly hard job to do, and a slip of the tongue or a little, one thing he gets wrong here and there, I'm not going to fault him for that, because what he does is incredible. So I have all the respect for that guy. And hey, the Harrison's Internal Medicine, he wrote some of those chapters. So I'll give him a mulligan.
I've known him for years. We collaborated with his lab in the 90s, and again, I totally agree with you, Mike. He's done an unbelievable job, a very difficult job, and yeah, we'll give him a mulligan on that one. But what's fascinating is he actually started out in autoimmunity before there was HIV. I mean, polyarteritis nodosa was his thing for a little bit of history. So, but it was funny, in the mid 80s, I remember I was just starting in med school. I was doing research on Coxsackie virus and its a potential role in juvenile dermatomyositis. So again, the role of a virus in a immune-mediated autoimmune disease in kids. There's just a recurring theme here. So, but a lot of us that were in virology in the mid 80s and, and then looking at autoimmunity, all of a sudden got pulled into HIV and immune suppression. But I think we were uniquely prepared to look at that, and Dr. Fauci was certainly one of them who came from the autoimmune field and completely understands the immunology of everything going on. So yeah, I share the same respect, trust me.
Dr. Patterson, so you and Mike were just talking about the randomized control studies, and one of the things when I started talking about leronlimab with a lot of my colleagues in ICU, my hemonc friends, my infectious disease doctor friends, was they said, well, where are these randomized control studies? Where are these trials that they've done in COVID-19 patients? I said, well, where were they with hydroxychloroquine? You're basing it on a French doctor who didn't use any controls in his study. Mike and I, we've made videos, we've talked about this on social media. We're not saying he's wrong, but it's very hard to make any correlations or say something works. I mean, that's just the basic of science and research. And then the same thing with remdesivir is we're having some evidence, like you said, there's some statistical significance reducing the infection from 15 to 11 days, but didn't do anything in terms of mortality rates. We're still obviously trying to get more data. Suddenly, it is a emergency or compassionate use has been authorized by the FDA. Meantime, we have leronlimab, which does not have any exclusion criteria. There's no serious adverse events, and I checked it on the NIH website. I kind of also go and do my own just to make sure I verify everything you guys said, and it's there. And I don't understand why everyone wants that I've talked to, the physicians, the critical care docs, say, oh, where are the studies? But they've given hydroxychloroquine and remdesivir and tocilizumab and every other drug except leronlimab. I probably talked about 6, 7 different hospitals, friends all over the country, been on conference calls. I got family members now that reach out to me saying, my mom's in the hospital, we want to give leronlimab. The doctors say no, the hospital says no. They're going to give hydroxychloroquine and remdesivir. And a week later, I get a text message or an email, my mom died, my dad died, my grandpa died. It's just every single week. Why doesn't the general public know about this? This is so outrageous and I'm not saying that leronlimab is the cure, it's the answer. I mean, we obviously need randomized control studies. There's some smoke, and where there's smoke, there's fire. And I've been telling my friends, listen, we need to investigate. Let's look it up. Let's see what leronlimab is about. And there's a huge resistance. And I'm not sure why that's the case. I mean, could you shed some light or your opinion on what I can do, what Dr. Mike can do to sort of tell our colleagues, hey, listen, just take a look at this drug. See what the science is, see what it can do, and maybe consider using it for thousands of Americans, thousands of people around the world who are losing their loved ones.
Mm-hmm. Well, I mean, I share the same frustration, obviously, but I do think we're closer now to the end with the trials. I think they're going to be dramatic, I don't think we have to wait much longer for validation that of where we stand in the COVID world. So, we'll do the right thing. It's frustrating for sure, knowing that what we've seen and what we've been able to do. And again, we're doing things the right way. We know how the drug is working. We've done the studies to look at the mechanism of action. And what gives it great credibility is that the outcomes are matching the mechanism of action. And that's what we haven't seen with the other drugs, especially remdesivir. We haven't seen, well, it's an antiviral. Well, we should see dramatic drops in viral load. Well, we didn't, but it shortened the hospital stay. I think people will always question, well, then what is it doing? But I think by by combining really strong science with the with Leronlimab trials, you're going to see that kind of cause and effect relationship. That, wow, it's doing what we thought it was doing, and oh, by the way, the clinical outcome matched that. So I think that's what we're looking at, and from right now, it seems like, well, you know what, maybe we're only a month away from getting approval, and we try not to dwell too much on how many lives we could have saved. It drives us nuts, but I think we're close enough to really make an impact in this disease course. And if we take away the specter of death, and we take away the fear of being intubated, or at least minimize both of those, we can get back to work, we can get the economy back on track, and we can treat this thing. And just like with HIV, there's never been a vaccine, but we're able to treat it and give people normal lifespans. That's my hope. So I think we're very close. The light's at the end of the tunnel.
And Dr. Patterson, the one thing, I don't know you guys. I mean, this is the first time I'm actually talking to you on a video screen. I don't know Dr. Porhasan and Dr. Lalazari. I've had a couple of conversations with them just to talk about the science. The one thing I'm really, really impressed is, and I don't, Mike and I we're not part of the biotech, biopharm research world. We're clinicians. We're in the hospital. Is how empathetic you guys are, how much Dr. Porhasan has jumped over so many hoops, how you've been involved, Dr. Lalazari has been involved with people from literally all around the world. I think one of the cases everyone's been talking about is Sarah Wright, who has breast cancer in England. I suddenly have gotten involved in helping that family out. I've been talking to the husband daily. We're hoping to have some good news for them sometime this week. But it was incredible how much care Nader and Dr. J, yourself, Dr. Doty, were involved in. It's almost individualized care. They were personalized. There were these emails and phone calls and text messages to oncologists in England and oncologists in America. I got Sarah's family in touch with a friend of mine I went to middle school with, who's a hem-onc doctor in Orlando. And you guys have been so supportive, and it's really, really incredible that I don't think that, and me as an independent, unbiased physician, when I see that in other people, physicians or non-medical people, researchers, that gives me a lot of hope that we're dealing with a group of people that actually genuinely care about others. They care about sick people and making them better. And I've seen that. And I'm not getting paid. Mike and I are not getting paid to say this, because I know social media is like, oh, these two doctors are getting paid. They're being endorsed by Cytokine. Absolutely not. This is just what I've seen from the numerous patients that I've just emailed Nader and you and everyone on your team and said, guys, this person here just emailed me. What do I do? And they get all the paperwork. They talk to the doctors. They get on the conference calls. It's really incredible. And that's just something I think people, the American public, need to know what you guys are doing.
I mean, it goes beyond that. I mean, when I got a picture of this this woman sharing Mother's Day with her mother who was on ECMO, I had a tear in my eye. I mean, every time we hear of somebody who was intubated and is now being discharged, your eyes well up. And people can say what they want and they can wait for the trials. I get it. But at the end of the day, there's patient lives out there, and you know what? It really gets to you. And you know what? I think a lot of healthcare workers are working long hours and suffering and have a full range of emotions. But even though we're in business, I think that's what's unique between Cytokine and IncellDX is we hear the stories of how it's helping, and we can't help but shed a tear.
Yeah, and thank you, Dr. Patterson, for all your hard work. And, like I said, Mike and I, we've been reading listening to your press conferences and reading your manuscript. And it gives us clinicians hope that there are top researchers like you that are not only looking at the science behind it, but helping clinicians like us, helping people, like bringing that human element, because we can get so caught up in the science and the immunology, and it's exciting and it's fun, but we're dealing with human lives. We're dealing with people, with families, moms, dads, siblings. Mike and I, we deal with this on a daily basis. We've had friends.
Right.
I've talked a lot about my friend, an old anesthesia partner of mine down in Florida. So, he's got really bad complications from COVID-19, probably going to be in rehab for the next year or so. Another attending of mine I trained with at Downstate, he passed away 2 weeks ago, died on ECMO, or getting transported to get ECMO. It's just, these stories, there are thousands and thousands of stories. And I know
just a 46-year-old doctor who in Arizona who was on ECMO, and he survived. And only 33% of COVID patients survive ECMO. I mean, he's one of the lucky ones, and it can happen to anyone, and it's so sad, all these stories.
Yeah, it really is.
Dr. Patterson, we've got sort of an exciting audience right now, and we sort of said we would do they might have a couple of questions. Would you have a couple of minutes to spare? And
sure.
We can, Mike, you got some questions that popped up on your end?
Yeah, I asked some of them already, but just real quick, do you know anything about T helper cell, T with the TH17 cells?
Yeah, I mean, we obviously we're looking at different subpopulations of T cells and actually different subpopulations of macrophages as well. So, yeah, we're in the middle of that. I think we probably got another 3 or 4 papers that we need to put out. So, I won't talk about that today, but probably at another time.
Okay.
So there was a question I had from, this is a little bit of a complex question from, we had all these scientists, Dr. Patterson, he sent me an email. Let me just pull this up real quick. His name is Jiro? Okay, so he goes, let me see where his question is, sorry. Okay, Dr. Patterson, in your preprint, you very elegantly correlated the administration of Leronlimab to the immunological benefits you'd expect as a result of Leronlimab's MOA on top of reduction of plasma viremia. This makes it close to irrefutable that Leronlimab is the cause of any clinical improvement in the patients. My question is, will these same metrics be measured using the same diagnostic suite for the P2 mild to moderate patients?
Yeah, we are, actually for both trials. The phase 2 and the phase 2b/3 on the severe patients. Yes, we are.
And his follow-up question was, while so far we have seen and have confidence in the effects of Leronlimab on the most critically ill patients, we, those not involved in the trials, have not seen its efficacy in mild to moderate patients. With your knowledge of the clinical course of disease for mild to moderate patients, what type of differences in terms primary endpoint measures do you expect to see between the Leronlimab arm versus the placebo arm?
Yeah, there's a clinical score that's being used as the primary outcome. And again, we haven't unblinded the study, so I don't know, but I'm seeing some pretty dramatic effects when I look at various markers. And until it's unblinded, I won't know, what it's due to, but I suspect.
Now, I know how you're going to answer this question already, but I'll ask it anyway. A lot of times, patients ask me, would you take it for yourself, or would you recommend your family member take it? So I'll ask you, would you take Leronlimab for yourself if, God forbid, you were to get it?
I'd have a bottle in my pocket if Nader would give me one. Of course.
How about you, Dr. Yo?
What's that, Mike?
If God forbid you were to get COVID, would you reach for leronlimab for yourself?
I told my entire family, if I get COVID-19 and I'm in the ICU, you are going to call Dr. Porhasan or you're going to call Dr. J and you're going to get leronlimab. And I told my parents too. My dad has got multiple heart attacks and stents. My mom had open heart surgery about 7 years ago. And I told them, if you guys get COVID-19 and you end up in an ICU, believe me, I'm going to be getting leronlimab. And if not, I'm going to punch every doctor in that hospital and beat every door and wall down until you get leronlimab. Because personally, I'm not saying it's the answer or the cure, but from what I've seen, talking to my colleagues, they realized sometime in the middle of February that hydroxychloroquine and azithromycin, in some instances with zinc, was not working in critically ill patients, maybe early, very early in the disease. And by early March, they had switched over to remdesivir, tocilizumab, and some of the other immunomodulators. And almost everyone said mixed results to it doesn't really work. It's all medicine's become about let's throw something against the wall and hoping it sticks. And when I look at the Monty study, granted, we've talked about it, it's not a clinic, an RCT, but there's smoke there. And I'm interested to know let's look into it. And I would want to give it to my patients and to my loved ones and to myself.
Mm-hmm.
Yeah, I would have to put my faith in Dr. Patterson on this one. So,
yeah, like I said,
if patients put their lives in my hands, I would essentially put my life in your hands with the leronlimab. Hopefully, it never comes down to that, of course, but it's always a question that I get asked a lot, and that's why I wanted to ask you.
I would.
Dr. Patterson, I got a question. Donna H. She just wanted to know about the manuscript, the abstract that from the Monty study that you talked about in your conference call. Any word on a publication? Is it sometime this week you guys are hoping, or pretty soon?
It's not an abstract. It's a full manuscript, and it's under review. And usually reviews take 2 months, but it's been 2 weeks, and I think we would absolutely expect to hear something this week and get comments. We've done so many experiments between when we submitted the paper and now that we kind of asked ourselves, well, what questions might they ask? And so we've already been asking those questions of ourselves, doing the experiments to address them so that when we get comments back, we can immediately turn the paper around probably within a day or two and hopefully get an acceptance quickly thereafter. So we're prepared for comments, and I think we'll be able to address them quickly.
Mike, got any questions there? Good questions for Dr. Patterson, not any controversial ones.
Well, it wouldn't be unexpected.
I think, can you guys still hear me?
Yes,
yeah,
Mike.
I can.
My Mac just shut down the EKM Live, so I think that's the end of my session.
Oh, Mike,
But,
I hear you, Mike. I see you.
No, but my EKM stopped because my Mac messed up.
Okay.
My broadcast stopped, but it's probably going live on yours still. So anyway.
Right, just stay on and talk, Mike.
Yeah, I'm here.
Okay. Dr. Patterson, one question I had been getting, I remember now, was actually I have two questions for you. The HIV trial, the patients on leronlimab, do you know what their status in terms of COVID-19 infections on those patients on those clinical trials, or do you have any information? That's a question I get a lot.
A great question. We did ask about it, and I don't know that we know of any that got COVID. So I any information. That we asked the same question, I think, probably a month ago. The other big question that we haven't discussed is, for instance, 26 out of 28 patients responded at the UCLA study. What if the other two patients had the delta 32 CCR5 deletion, and were homozygous for it, in which case they don't express CCR5 on their surface. So, although the homozygous state is very rare, it's common in Northern Europeans, and obviously heterozygotes exist. But we haven't done any CCR5 genotyping in COVID. We did that routinely in HIV. But I think that's another important thing where, if we do get some discrepance or some outliers, I think we'll investigate. That might be one of the first things we do to investigate.
And my other question for you, Dr. Patterson, is maybe not Leronlimab or RANTES associated. It's more, obviously you're sort of an expert in cytokines and doing your research. Is there, what I've seen in some of the ICUs is we have patients that they had COVID-19 infections, they recover, they're PCR negative, they get discharged from the ICU back to the floor, and the very next day they're in a cytokine storm and they decompensate very quickly. Is there a possibility that, or do you think that we are really focusing so much on the virus and not so much the cytokine storm, that we're looking at these patients saying, all right, they're negative now, their risk of having these storms is gone. There's no risk, and they're discharged to the floor and onto a rehab facility. What's your opinion on that?
But that is a great question, and then that really relates back to what I said about this this dichotomy between the virology and the immunology. Because I'll tell you, we monitor patients out to day 28. There's patients at day 28 who still have elevated cytokines and chemokines, and there was, I think, one or two patients who, for one reason or another, Leronlimab and didn't have a third, or one patient had one dose but didn't take a second one, and you see things going down day 3, day 7, which is the length of time of the first dose. They didn't take the second dose. Day 14, you have a recrudescence of the interleukin-6, RANTES, everything else. So it's very important to understand that the immunology of this disease does not correct on the same time course as the virology, and that is absolutely critical.
And I got one more question for you, Dr. Patterson. Is sort of the big question everyone's been asking is, can Leronlimab, should it be used with remdesivir, or can it be used alone as a standalone drug? I know you mentioned that, and I'm looking at your manuscript and going, wow, it reduces plasma viral loads, and you got remdesivir, the antiviral, that's not really an antiviral in my opinion. Me personally, I don't see why you would want to mix it, but I also see the reason why you would want to do a combo. What's your opinion on that?
Well, like I said, there's 3 boxes to check. Restoring the immune system, quieting the cytokine storm, and bringing the virus down. And Leronlimab does all 3. And the second thought on that is, why would we want to bring on the side effect profile of remdesivir on a perfectly safe drug? So that's my answer.
Great. Mike, do you have any questions? I know we've probably exhausted Dr. Patterson on a Sunday night.
Well, no, I've asked all the questions I wanted, but I really do appreciate your expertise and coming on and doing this with us. So thank you.
Yeah, thank you very much. And Dr. Patterson, I hope sometime in the future we can do this again. We love talking. Mike and I are a bunch of nerds. We love talking medicine with very renowned experts like yourself. And it's not every day we get a chance to talk to someone we highly respect and whose work we're closely following. So we really appreciate your time and sharing your knowledge with us. And
So you do good work too, and keep getting making this understandable for everybody, and I think that's absolutely critical. And we'll keep in touch. Obviously, we have an exciting month ahead of us, and we'll see how it goes.
Sounds good. Thank you.
What we'll do is for the viewers that are watching, we can they can ask us questions that they have for you, and we can relay those to you. And next time we speak with your email when it comes to RANTES and the Leronlimab, and my Instagram where I can get questions would be Dr.Hansen, Hansen, and Dr. Yo.
And yeah, mine is ECA Wellness, ECA and Wellness. It's on Instagram, and you can also find us on our YouTube channels. Dr. Yo here, and Dr. Mike Hansen is Dr. Hansen's. And yeah, if you guys have any questions, we can, we would really enjoy picking Dr. Patterson's brain and having him share some of his knowledge. So again, thank you, Dr. Patterson, for spending your Sunday all this time with us. We're super excited. So thank you very much.
Yep. Be safe, everybody.
All right.
Thank you.
Thanks. Take care.
Thanks, Dr.
Thank you.
Take care.
Good night.